Okay. Thank you guys for showing up. So, I don't know, I always think the best way to, I'm not going to be able to talk for an hour with this on, so hardly. I always think the best way to demonstrate grossing is actually gross, because seeing words and pictures on a screen, I think, is less effective. So, what we've been doing for the past couple of years is either trying to gross like live specimens or autopsy stuff. So, thank you guys for getting this organ from autopsy. So we have a tongue and a larynx, and I should probably rinse it first, and a thyroid. Let me just start with some water, because otherwise it's going to kill me. Is this the first one you guys were having?
The first thyroid?
Oh,
grossing lecture. Yes, yes.
Okay,
You were the very
right.
first lecture of the academic year. Yeah, quite a distinction. Yeah.
So the pressure is on. Okay. All right. So, in general, how has it been going for the first years, for your first? Thumbs up, good, not, okay.
Turn around.
Okay.
They've been working really hard. They've been keeping this table looking incredible, really amazing. Yeah.
If there are cases that you grow during these training weeks that you want to see the slides for, make a note of it, and you can definitely follow up with us. We're always happy to show you cases, whether it be the resident or the attending or whatever. Fellow, always call us with questions. There is never a question that is too small, or there are no stupid questions, and often we can provide you hopefully some helpful answers. What else? Anything else, sort of disclaimers that we need to talk about?
Questions are good. When you don't ask questions, bad stuff happens sometimes.
When you don't ask questions, bad stuff sometimes happens. Exactly. Okay. All right. So, cool. So please step in, if you can't see, and you can zoom in as close as you need to see. So basically, they have exhumed a tongue. You can see here the tip of epiglottis with the larynx that's going to be in here, all the way down to the trachea, and a little thyroid gland in front, right? So anatomically, this is sort of sitting in the patient like this. And so we're going to talk about some sort of general concepts with specimens that include mucosal or skin ellipses, and we'll talk about thyroid, and if we get a chance, we'll move to larynx. We can always save larynx for another day, because that's a little bit complicated, but at least it's on the specimen, and we have it, and we can do whatever we want with it, and that doesn't matter, because it's not a patient case. I mean, it's not a live patient case. Okay, so, and if there are any numbers, maybe just try to hide them from the camera. Oh, it's a good idea. Okay. All right, so anybody want to tell me what these little dots are on the tongue? Circumvallate papillae, thank you. And why are they important? Okay, so they separate basically the anterior or the oral tongue from the posterior or the base of tongue, okay? And why is this anatomic division important? Okay, and so squamous cell carcinomas are definitely the most common carcinoma of the mucosal sites. Is there a difference between those that arise here and here? HPV. Okay, so exactly. So we're going to learn some pathology while we learn some grossing. So up in front here is going to be mostly alcohol, tobacco, betel nut chewing, environmental carcinogen-related tumors that are keratinizing. Back here is the base of tongue, which includes the lingual tonsil, right? So this is actually tonsillar tissue down here, and it mostly develops HPV viral-associated carcinomas, okay, which are actually good or bad prognosis for patients. Better, exactly. Better prognosis. So when you get specimens that are labeled as BOT, base of tongue, that's this, or posterior tongue, we don't have the tonsils here, but imagine, right, coming up here would be your tonsils that are tucked in between your palatoglossal and your palatopharyngeal arches, right? And then you have the palate, and then actually, what's going to be the best way to do this? I don't know, the uvula, right, dangling down here, and then up above the uvula, you enter what cavity? Nasopharynx, okay? So the larynx is an important sort of anatomic divider in terms of the sites of the pharynx. So if you picture, you know, oral cavities, this right here is regarded, the base of tongue is regarded as the oropharynx, okay, because it sits in the portion of the pharynx that is behind the tongue, okay? This muscular wall here is what? Is the pharyngeal wall. So if you stick your probe in the larynx, okay, that's the larynx, right? But if you stick your probe behind the larynx, that's the pharynx, and what is that continuous with? Esophagus, exactly. So food stuff, exactly. So right down here, right, esophagus. So air, food, esophagus, trachea, larynx, pharynx, okay? Posterior pharyngeal wall is this muscular stuff that I'm holding on to, right? So oropharynx is behind the tongue. Laryngopharynx or hypopharynx is behind the larynx. And nasopharynx is up here behind the nasal cavity, all right? So those are our three pharyngeal sites. So HPV cancer is here, EBV cancer is up here, okay? All right. Okay, hopefully those sites are a little bit, you know, we can demonstrate them. When you proceed from the base of tongue to the larynx, you have these two little pockets. What are these pockets called? Valleculae, exactly. And so food stuff can, like boluses of food, can roll through the valleculae, press the larynx down, so that the food can go back here into the food pipe, right? Exactly. So that's this portion. Once you hit the epiglottis, then you're either in the larynx or in the pharynx, okay? But to continue on the anatomic sites of the tongue, right? So we have posterior, anterior, we have, you know, tip, right? We have lateral borders, okay? And then we have, what is this considered? Ventral surface, exactly. So dorsal, ventral. They cut the ventral tongue off from what anatomic site? Floor of mouth, exactly. So right down here would be floor of mouth, and up here would be mandible. So you see FOM, F-O-M, that's floor of mouth. You see BOT, B-O-T, that's base of tongue, all right? And then otherwise you see, you know, antero, you know, lateral border, dorsal surface, ventral surface, posterior base, all right? They're going to be using all these terms to identify these anatomic sites of tongue. But this is what it is, okay. Anteriorly, right, they've taken the larynx out of the neck, and so you see some remnant of the strap-ish muscle. You see probably a little bit of, you see a little bit of thyroid gland, which I think has a little bit of tiny nick in it. That's okay. Okay. So, yeah, the thyroid is not thought to have, is not thought to have an actual capsule. I just nicked it again. Just like the prostate does not have an actual capsule. But it has a tissue plane, which I am now cutting through, right? So when they do thyroidectomies, they cut through this tissue plane, but there is no real capsule over the thyroid. It's just this nice fascial plane. So that'll be important when we talk about sort of grossing and fixing and stuff of thyroid, and it's important to maintain this fascial plane in as much integrity as we can, because that's the surgical margin, okay? The thyroid sits, as you can see, sort of on top of the larynx/tracheal sort of junction, and wraps around, here's the left lobe, the isthmus across, and then the right lobe. And in this case, it sweeps way posteriorly. The right lobe here sweeps way posteriorly. And occasionally, if you're, oh, we found Exactly. A parathyroid. All right. So sometimes we don't see these because they're tiny. But in this case, I cut right through it. It's a little brownish nubbin that exists right adjacent to the thyroid. In autopsy, we try to find them. If we don't, we don't. But hey, we found one. So great, we found a para. There's sometimes, above, below, behind the thyroid gland. They can vary in location, but they are uniformly there at some point in space. All right, so I'm just gonna grab this guy off and maybe set him aside. All right. Or we can just leave him and deal with the tongue. Maybe we'll leave him for now and deal with the tongue first. Oh, is there another one? Wait. I think there might be another one. There it is. Nice one. All right. I wonder if they're probably easier to find after fixation because they kind of get firm and really brown. Exactly. Really, really brown. All right, cool. We found 2 paras and a thyroid. 1, 2. Okay, tongue. So let's talk about grossing of mucosal and skin specimens. So I think this goes for most specimens that involve some kind of mucosal surface or skin surface, right, with a lesion. And so I think what I'm going to do is maybe take a portion of tongue out and pretend it's a surgical specimen. Does that work? And then we can sort of talk about it from there. And now that we've got the anatomic sites, I think we're going to say goodbye to you. You aside. Okay. So most mucosal specimens have some sort of, I'm just going to have some sort of anatomic orientation, landmark. What's going to be the best here? I'm actually going to just do a nice square rectangle. Okay. All right. So we can imagine this as a resected, portion of tissue. If it's coming from the, oral cavity, it's going to have squamous mucosa. Coming from the superficial sites, it's going to have skin, right? But and fat instead of muscle, but essentially it's going to be the same concept. And it's not always perfectly square like this, right? Sometimes it shouldn't be perfectly square because they're trying to preserve lines, right? So it's going to be an ellipse that they taper. Okay, but you can deal. All right. So sometimes it's oriented as a clock face, right? And sometimes it's oriented by anatomy. My advice is if you can ever orient it by anatomy, that's preferential to maintain those anatomic relationships rather than replacing them with a clock face number. If all you have is a clock face designation, sometimes the skin surgeons do this, Gottlieb or whatever, he'll just put a suture at 12. Then you can just say, all right, 12, 3, 6, 9. He knows where 12 is, even though we may not know where 12 is, he knows where 12 is. It's usually, however they're facing the patient, it's like a clock to them, right? So if they are on the patient's, side, 12 o'clock might be, medial. If they're up at the patient's head, 12 o'clock might be like inferior, right? If they're below, it might, so we don't always know, but anyway. Okay. So, and it may or may not always actually be 12 o'clock to us, right? Like superior. Okay. But if they say, sometimes they will tag it with 2 sutures, like short, superior, long, lateral, or something like that. And then you know exactly where you are. So if one is anterior, 2 is posterior. If this is lateral, then this is medial. Or if this is right, then this is left. Okay. If you're on the tongue, if you're on the lateral border of tongue, that orientation might shift. So then this might be superior and this might be inferior. All right. So then it's going to sit like this as opposed to like this. And sometimes, right, if you're on the ventral surface of tongue, it's going to be, this is actually going to be like quote unquote superior and this is going to be inferior. So you sort of have to know where kind of along the tongue you are in order to understand those relationships. And usually the head and neck surgeons do tag them with an anatomic site. Okay, rather than 12369. But 12369 is always a safe way to go. Okay, so when we, we always measure, photograph. We will do another lecture on gross photography, and maybe we'll do it like in one afternoon. I think you've got it on the calendar. We're gonna have snacks and stuff, because I don't know, I think it's just fun to do, because it's a fun lecture. Photographing the external surface of these specimens is incredibly useful for orientation, and even inking. So, sometimes specimens don't get photographed after they get inked, which generally is fine, but sometimes they do, and if they do, it actually helps if there's ever a question on, oh, which was inked? Black, blue, right, left. So sometimes that's helpful. So more photographs is always useful, less is worse. Okay, more the better. So don't hesitate to take photographs. But if you take a photograph of something in the intact state to determine the qualifications of the lesion on the mucosal surface, for example, you are also going to want to take photographs of the cut sections to determine the characteristics of it on the cut sections, because, the outer surface is not the most important thing always. This goes for every single specimen. Whether it's a soft tissue sarcoma, that you have, a ball of fat, and you take a photograph of the ball of fat, but, if I don't have a photograph of the cut section of that ball of fat, it's essentially useless because I don't really know what it looks like. Same with like a thyroid. If you have a photograph of the external surface of the thyroid to let me know what the orientation is, great, but then also take photographs of those cut sections of tumor. Okay, that's thing one. Thing two, we'll talk, I guess, about inking and frozen and grossing. So for most specimens that are tagged with, some anatomic orientation, I advocate for essentially two colors in the skin and mucosal ellipses, with like a lump of breadth, right, where you don't have skin or mucosa. You can't just use two colors. You have to use those, at least 4 to 6 colors. But we already have one landmark, which is skin, right? So generally the concept is to do one side in one color and the other side in another color, and meet all those colors together. So if this is, let's just say anterior, posterior, right, left, okay? So we are going to do all of the soft tissues on the right one color, and all of the soft tissues on the left another color, all right, and meet them in the middle, so that when we do our sectioning, so we always like to think about what things are going to look like when we place them in the cassettes, how we can keep them oriented, and what they're going to look like on the slide, right? So in this case, if you know this is anterior and this is posterior, you don't necessarily need separate colors on anterior and posterior, because you're going to cut these off, perpendicularly section them, and tell me in the cassette that it's anterior, right? Same for posterior. You're going to perpendicularly section these and tell me that it's posterior. So I don't necessarily need opposite colors on these surfaces. Same with the lateral side and the deep side. So sometimes the surgeons will ask to ink the deep separately. And that has gotten into a few problems before in large specimens, where then the deep is all one color. You don't know whether it's more towards that side or more towards that side if you just take a section from the middle, which is why we do two colors and meet in the middle, so at least you have some like closer orientation of which relative side you're on. But then the surgeons ask, well, how do you know whether it's peripheral, like perpendicular, like how do we call these, radial? Let's call this radial, or deep. Well, you can see it on the slide, right? It's generally, these are tidy specimens in which they turn corners, right? So the mucosa turns the corner to the perpendicular, and the perpendicular or peripheral turns the corner of the deep. Even if it's not a 90-degree angle, it's some kind of slope where you can say, yep, this is opposite mucosa, so it's deep, whereas this is, at a 90-degree angle to mucosa, so it's peripheral. That's usually not an issue. Like, there are corners. So two colors, fine. What questions do you have so far?
Even if the surgeon points to an ink and tells you to use this color for the deep, you can be brave and redirect.
Thank you.
Thank you. What an excellent suggestion.
Sometimes they will have artifactual, oops, I cut that intraoperatively. That's not a margin. So when they do that and they make artifactual clefts in the tissue, what color do we use? Orange. We love orange first. We love orange for defects, exactly. So orange is, at least, I don't know if this is true for other services, but is it true for other services?
I think it's for,
You don't really get it.
I have like a weird breast margin with like crazy.
You don't get oopsies or oopsie requests.
But I guess I've just started using orange for the defect.
Yeah.
Yeah, and everything. Yeah.
Great. Then if you have consistency, it helps.
Yeah.
And so we were talking about this yesterday when we were inking the other lip. The other convention we use for black and blue is left and right. And why?
Sinister.
Left is sinister, and so left is black. And so then right is blue. And black and blue just tend to stick, I think, better on tissue and be really nicely visible on the microscope, whereas the others stick less. And it's honestly, it's really sometimes hard. I don't know, you guys are probably better at it, to tell between like blue and violet and like orange and red. I swear I must be like, it's a nightmare.
Oh yeah.
Oh, seriously?
Yeah. There.
But in general, yeah, like if there's an alarm or an alert in the ICU or something, red versus green might be important.
Vinegar for fixation, not fixation, like attachment of ink to tissue. So I usually put a gauze on and spray the vinegar and blot the gauze, because then the ink kind of, whatever excess ink sticks to the gauze, and it will less often stick to your fingers. So I don't know, I'm insane about vinegar. Every year I say this, I'm like, I like vinegar on my specimens and I like vinegar on my salads. So I am not shy with vinegar. All right. After 9 years, you find yourself saying the same stuff. You're like, Nicole, you're a broken record. Move on. .org. Okay. All right. So here we have now our oops, I totally did it backwards. That's fine. We have black on our left and blue on our right. And now my posterior tongue is anterior. Okay. All right. So you will often be asked intraoperatively to freeze these specimens for the quote-unquote deep margin. So what they're doing, whether it's sometimes it's skin, most often it's mucosa, what they will have done is they will have resected this little chunk from the patient. They will take, so if this is in continuity, if this is in continuity here, what they will do is they will take a little strip of this mucosa, right, and they'll send 3, 4, 5, 10 of these for frozen. And those are your mucosal margins. And these, generally, they don't orient between this side and that side. So you can just freeze them on whatever side is appropriate. And as long as you see mucosa and whatever tissue below it, that's the margin. And they do that around all 360 degrees basically for dysplasia in situ carcinoma, and very, very, very superficial invasive carcinoma. Mostly this is a mucosal disease evaluation, okay? What they will then do is they will sometimes take a little tiny piece of skeletal muscle and say, deep margin, and send that to you for frozen. But the thing is, right, no one knows where this little piece of deep margin is on the specimen. So what they do is they send you the specimen and they say, you tell me my deep margin, okay? So how do we do that? Do we look at the bottom and say, let me cut into it and find where tumor is? No, you gross it. You basically gross these fresh. So I think I had a conversation about some specimen the other day, and I was really happy with you guys, because after all of this time, I think you guys now know how to handle these. You are teaching the other attendings who are on frozen how to handle these. So thank you, thank you, thank you. And so what you want to do is basically essentially gross it fresh. So whether you're doing a frozen or whether you're doing a permanent section, we're going to gross it together. So so always photograph the intact state, okay? Once you section it, it is actually sometimes really nice to have, at some point, all of those sections photographed, especially if you're doing a frozen on it, then we know exactly where you took those frozen pieces from. And then thirdly, we always like one nice representative section of sort of the bulkiest, juiciest, most beautiful section of tumor. That's like close up, okay? And we'll talk about that in the photography lecture. So when you gross it, you're gonna start from one end and go to the other. Some people find it easier to do this way. Some people find it easier to do this way. I don't know, you'll find your own. But I always advocate taking this hole a little bit deeper than you would normally take just a representative section. So how thick should our sections be? 0.3-ish to put in a cassette, right? But if you take this at 0.3 and then you try to perpendicularly section it, you're going to get little floppy pieces that flop over for your margins, okay? So for your tips, for your poles, for your margins, I say take it deeper, because then when you perpendicularly section this to evaluate the approach of tumor to that margin, you're actually going to get nice pieces of tissue that lay down properly and histology can actually embed, right? So if you think about, if you ever want to watch the histo do their embedding, it's, you know, potentially informative. They're dealing with hot wax, right? That's sort of cooling. And the nicer your sections are, the easier they can lay them in the wells. And especially if you give them, you know, multiple pieces in one cassette, that wax is like slowly cooling, right? So they put a piece down, the wax cools a little bit. They put the next piece down, it might be slightly up. And they put the third piece down, it might be more up, right? So the fewer pieces you can put, the better. The more flat and even they are, the better. And that'll result in more even embedding and more even kind of layering when they cut the blocks. Does that make sense? Okay, all right. So margin A, all right? And then we're going to walk across the specimen and do our thin sections. This is a little bit juicy, but you basically do that the whole way through, and then you do the same with the other margin, and so you have margin, section, margin. Yes? Okay, but we're not, for the sake of time, we're not going to do that. One thing we already noticed is this colored change. Why is that? Not fixed. So the center, when it looks, you know, reddish compared to the periphery brownish, means under fixation. So if you ever have sections like this that look reddish in the middle, you may want to not immediately throw them in the rack. You may want to put them in your cassette and put them in a little bucket of formalin and let them fix for a bit longer before you submit them, so that this gets more fully fixed. And so you'll see when you look at the slide, fixation artifact, it looks kind of, I don't know, how do you guys describe it? I describe it like milky, like the tissue doesn't look like it has contrast, like it looks kind of watery. And so you'll be able to see those fixation differences on the slide. So this is a little bit yet underfixed, but that's okay for our purposes. But we see that we have a nice black edge here that meets, you know, the black meets in the middle with the blue on the bottom. There's a corner. So we have our nice margin. We have our mucosa. We have our deep. We have our peripherals. Okay. So in this case, if you're doing this for frozen section, you're going to want to evaluate both the extent of tumor to each relative peripheral and the deep. And so you're going to want to freeze anything that is close-ish. What is close-ish? So in head and neck cancer, a positive margin is anywhere between at ink to like 3 millimeters from ink. They will go back and take more for any tumor potentially within that range. 1 millimeter is definitely positive. All right, less than 1 millimeter is definitely positive. So this isn't like thyroid or prostate where it has to be on ink. This is a wider margin, okay? So 1 millimeter is positive, anywhere up to 3 millimeters is positive. So if you see the tumor and it's like up here and it's, you know, 5 millimeters from here, 5 millimeters from here, 5 millimeters from here, honestly, sometimes I call those back as gross only. So like it's grossly 5 or more millimeters from the margin. Are you okay with, are you comfortable with that? Mostly alcohol and stuff will say, yeah, I'm okay with that. If they don't, if they say, no, can you freeze, then you gotta freeze. But if you're like, yeah, that's not near it, and I know that this is normal skeletal muscle, like what is a microscopic section going to necessarily add in most circumstances? More often than not, there's something that's close, right? There's something that's here, So you might want to freeze that lateral section. There's something that's deep, you'll want to freeze that deep section. If there's nothing over here, then you don't have to freeze that, right? So you only want to freeze representative closest. I would argue probably no more than two, no more than a perpendicular and a deep, okay? And please, if the attending reports negative, but you see it on the slide as like 2 millimeters, maybe kindly say, hey, a positive margin is anywhere between 1 and 3, so you can tell them the distance. Okay. And depending on the circumstances of the patient, they may or may not take more. If they're like, I have no more to take at this particular location, or the tongue is retracting, I'm okay with 2, fine. What if you're like, oh, it's 2 and it's really big, and he's like, okay, fine, I've got a lot of tissue, I'm going to take more, right? So just go, we tell them information, and they make clinical decisions. Okay, what else can I tell you about? Oh, submitting to SET. So in ellipses, how much should you submit? So smaller-ish specimens, you can generally submit entirely. We're pretty liberal with submitting in head and neck. Larger things, certainly you would not want to submit entirely. And always ask us, for advice on how to do it. Sometimes we do every other slice. Sometimes we do every third. Sometimes we do it all. We like to keep the slices numbered, just like in breast. So this would be slice 1, margin 1, 2, 3, 4, 5, 6, 7, posterior margin, whatever. So then if you need to go back to the bucket, if you haven't submitted it all, you can identify which slice you want to submit. And I think keeping things in numerical order like that is pretty nice for most specimens when you can, when there's an organization that allows it. If you are, I think they changed the breast protocol recently to also not have you submit the entire medial lateral margin. Is that correct? Yeah. So, when you are dealing with any specimen, my advice is, if you are submitting the specimen entirely, submit it entirely. If you are not submitting it entirely, you don't have to pick and choose portions of it to submit entirely. So, for example, you do not have to submit the entire anterior or posterior margin entirely if you are submitting the remainder of the specimen representatively. So that's my rule of thumb. So you can always wrap these things back up and save them for later if you need them, right? But if you have a nice visible tumor right in the middle here, and this is all grossly negative, you're not adding any more information, and you're creating more work for histology, right? So I'm so glad that breast has changed that now, because similar concept, right? Like, you can always go back, but you can't remove work that's already been done in a lab that is often already overwhelmed, right? So we're trying to create this balance between information and work. Okay, so that's my rule of thumb. Submit most things representatively unless directed otherwise, including your margin. Keep things in order. And any other advice from the peanut gallery? No. You do your conversation. Okay, yes, how do you do it?
I use the breadcrumb marker, and I was like, 1, 2, 3, 4. I fold it in half, and then
Cool. And no, that's good. So this would have a marker on it, 1, 2, 3. You can even draw lines, whatever. The thing I would avoid doing is rolling it.
That's dangerous.
Yes, that's dangerous, because then you have specimens that fix in a rolled position, and you can't lay them flat. So fold and press.
And like put another paper towel around it, or else they might fall out.
Yes. Yes.
you can put a rubber band, but not too tight.
Not too tight. Yes. Right. And you don't want the stuff to fall out, right? So then you want to put something on the ends of it, right, to not have it fall out, and then you can lightly band it. Great. Okay. It's like phyllo dough, right? It's like layers. Okay. Now your Greek heritage is coming out on you. Okay. All right. So we have our phyllo dough wrap thing. We open it up, and then the sections remain relatively flat, void. Okay. What other advice from the peanut gallery? I mean, peanut gallery. I mean, the amazing rubs that are here.
Oh, make sure
they really are.
you go right up to the edge.
Okay, awesome. So touch the ink up to the mucosa. Great. You don't want gaps, because those are still margins.
And then if you're telling it, you can use water and try to use it.
Right. Yeah, if ink on the mucosal surface is sometimes less bad because you can tell. Ink bleeding into crevices is bad, right? Because then you don't know. Well, sometimes
At the bottom, you gotta make some kiss.
are they kissing enough for you, Jackson? Okay. Make them kiss and make them kiss. Okay. I love it. You guys are great.
Romance movie.
Romance movie. So if you get this for frozen and it's wobbly.
Oh, I was about to ask. Yeah.
Yes. So sometimes these specimens are wobbly and gooey and juicy and fatty and muscly. And so if you feel uncomfortable cutting them because they're like slipping under your fingers, we can take the fresh mucosal ellipse with a little bucket of liquid nitrogen and dip it in liquid nitrogen so it firms up. And then you are more able to cut the sections cleanly. So it acts almost in place of a fixative, right? Because fixative firms up the tissue, so does liquid nitrogen. But if you fix the tissue, you can't freeze it. And if you freeze it in nitrogen, you can still freeze it in the cryostat, and you can still fix it later. So it doesn't like really harm anything by doing a little bit of liquid nitrogen to solidify it. There used to be residents that like it, residents that don't like it. If you want to try it, you know, we can help you out, but it's available if you want it. What else?
Just to like reassure the first years, like for all of these, like the PAs will help you at the beginning. Like you're not going to just do it alone.
Yeah.
So talk through your plan.
Yeah. All right. Questions before we move to thyroid? We have what, like 20 minutes? Yeah. Okay. Oh no, is that another one or is that just something brown? Our lucky day, guys. Oh, let's talk about parathyroids while I do this. So what's the most important thing for parathyroid? Weight. So sometimes parathyroids are unexpected and they come labeled as like neck blip. You're like, okay, you might not know that it's a parathyroid if it's labeled as, you know, neck blip. But if anything on the container label says parathyroid, no matter how small or big it is, you should weigh it. Weigh it before you fix it, before you freeze it, before you dunk it. So sometimes we get parathyroid, like basically identify parathyroid, rule out tissue for frozen. Please try to weigh that as much as you can on the nice, the 3 decimal scale. And so for parathyroid, it's nice to see all 3 integers after the decimal on your grocery list. Because weights are important, right? So we're dealing with milligrams, not grams, right? So 20 to 40 milligrams, normal. This is fixed. We weigh it. Let's see what it weighs today. All right, it's a little heavy because it's fixed and it has fat. So 76 milligrams. Okay. So 20 to 40-ish is normal in a non-fixed, non-fatty parathyroid. Anything larger than that is abnormal. So way. 3 digits. Same with thyroid. Same with any endocrine organ. Weight. Okay. All right. So thyroid. What? Excellent question. You can do both. You can weigh it intact as they give it to you. You definitely, if you can identify fat and trim it off and then reweigh it, I would say yes, do that. Because that is a more accurate representation of what the actual glandular component is. So now that we have that question, we'll trim whatever fat we can. Let's weigh it again and see how much fat goes. So it got rid of like 1.3. Okay. It got rid of the entire weight of a normal parathyroid gland. Okay, awesome. Thyroid. So a little less lobe, a bigger wrapping around right lobe, a pyramidal lobe in the middle. Sometimes, an isthmus in the middle. Sometimes developmentally, you may see a little peak up the middle, right? That's the pyramidal lobe. How does thyroid develop? Thyroid lossal ducting goes down. Where does the thyroid lossal duct start? Base of tongue. So,
Foramen cecum.
yes, so basically here, right? It starts here as a little condensation of tissue, dives down the tongue, dives down the anterior neck, and solidifies here. Exactly. So you can have ectopic thyroid anywhere from the base of tongue, through the hyoid bone, which sits here, which we don't have. It usually goes in the hyoid bone and out, all along here and here, and it can even go farther down, right, and go into the medial spinum, right? So anywhere here you can have ectopic thyroid tissue. Generally, it places itself, here. Great. So the pyramidal lobe is sometimes a little remnant of that development where it has a little dip in the middle. We don't really have a pyramidal lobe here. That's fine. Okay. We can generally think about thyroid in a few ways. One is the patient has some kind of medical disease like Graves' and Hashimoto's, where they're taking it out for symptomatic like adjustment, whether it be it's big and it's compressing their structures, it's medically unmanageable, right? And they want to medically manage it with Synthroid rather than other meds, so they take the lobe, usually the whole gland out. If you see a medical disease case where only one lobe is out, generally that's either because there's a lesion in it and they want to get rid of it for the lesion, or because they had some issue intraoperatively with the nerves and they aborted and they'll go back for the second operation later. Okay, but in those cases, representative sections of thyroid are fine. So how would that usually look? So there are a few ways to section thyroid. I would argue, can I avoid inking this now just to save time? Okay, so, but just like the other things, we do left black, right blue. And in this case, we actually do orange for isthmus. So if the isthmus is appreciably long, as it is in this case, we put orange on the anterior and posterior side. If there is no real isthmus and the lobes are real tight, then I would say just avoid orange and it doesn't really matter. It's just kind of an anatomic nice sort of designation. But this has a pretty appreciable isthmus, so we would ink in 3 colors. There's some literature out there, and in institutions you may see out in the world, ink the posterior surface a different color from the anterior surface. Why? Anybody know why? Well, it's all margins because of potential invasion in the trachea. Maybe. The reason they do it is because of potential differences in recurrence risk from a positive anterior margin compared to a positive posterior margin.
Really?
Yeah, this is new information out there in the world. So there's one paper out there saying that a positive posterior margin puts the patient at increased risk of recurrence than a positive anterior margin, potentially because there's microscopic disease in the trachea that you can't get out. Anteriorly, if it goes anterior, it's probably just going into the strap muscles. Maybe it's easier to excise, whatever, I don't know. So that's one paper out there. Some institutions do posteriorly different, but our clinicians don't really use that information to do clinical decision making. So we do not do anything differently for the posterior.
How would that inform the clinical care going forward?
So either they might choose to give radioiodine when they wouldn't. They may choose to monitor more closely for recurrence or have a higher index of suspicion that the patient will recur. But generally, if it's a positive margin anyway, and the tumor is significantly,
regardless of,
you're going to give radioactive iodine anyway, regardless of whether it's anterior or posterior. So our people don't really use it. Okay. All right. So then, let's pretend we have this now inked as a total thyroidectomy specimen. And in this case, I'm gonna isolate the isthmus from the lobe. If you wanted, you could do the isthmus right in the middle. Honestly, I'm flexible with how you broach the isthmus. I think one of the reasons that we amputate the isthmus off is so that it's the plane of sectioning. It's just easier then to have, left lobe, right lobe isthmus, and then you can nicely sort of section your isthmus in a fashion that walks you from right to left, right? So you now have the section closest to, these paper towels, and the section closest to the right, the section in the middle, and the section closest to the left. And so if you have tumors that are like invading the isthmus from the lobe, you can nicely see, oh yeah, that's the section most proximal to the lobe. It's in there, so it's just continuous, for example. The other thing you'll see in these isthmic sections might be what? Might be lymph nodes, okay? So there's fat and lymph nodes in the central compartment around the region of the isthmus. So always identify little nubbins out here that may or may not be lymph nodes, and always try to submit those entirely. So even the only thing that you pretty much always want to submit entirely are any lymph nodes that you find, okay? For most specimens, I would say that's generally, you know, a rule of thumb, or whatever your maximum is for colon.
There's no max.
There's no maximum. There's just there's a minimum, I should say.
Minimum, yes.
There's a minimum of 15. There's no maximum for any specimen submit entirely.
I just spent my entire Saturday
Doing lymph nodes?
for 3 colon.
Awesome.
So,
Great. All right, so that's isthmus. Then we have lobe. So if you have a hemithyroidectomy specimen or a lobectomy specimen where the surgeon has cut it at the isthmus, this is now a surgical margin, right, as well as the periphery. So this is also where we would ink this a separate color from the boundaries, the peripheral, because this section, if this is a surgical cauterized plane, this plane is in continuity with the other piece of thyroid in the patient, right? So this margin is conceptually different from this margin, right? Because say there's cancer, right? And there's a positive margin out here at the periphery. That is not an indication for reoperation, right? That is an indication for potential radioiodine. They don't go back for positive margins in the thyroid in the periphery. But if you say, oh no, it's actually positive here, it's still in the patient, one, they go back and get the other lobe, and that's not a sign of aggressive behavior, right? A sign of aggressive behavior in thyroid is coming out peripherally. It's not tracking through the lobe, right? So this is just normal behavior for thyroid. This is bad behavior. So we want to delineate. So this would get, you know, orange ink, and this would get black or blue ink, all right? Then there are 2 ways to section thyroid, which we'll talk about the reasons why. So for most cases that are small or medical disease or cancers, we can do our regular, just top to bottom transverse sections, including, right, this isthmic margin in those sections. So now we are no longer dealing with, you know, a total thyroidectomy. We're dealing with a lobectomy, and you're serially sectioning these perpendicular to that isthmic margin, and all the way through top to, you know, stem to stern, however you want to call it, and you have these sections, you know, that include your isthmic margin and your periphery, and you identify for lesion, okay? The other way that we have sort of recently considered sectioning these thyroids is if there is, this is maybe not quite large enough, but we'll try to demonstrate anyway. If there is a large-ish nodule, our rule of thumb is sort of maybe 2 centimeters or above, that is an indeterminate cytologic diagnosis, meaning they've had an FNA and we don't know whether it's benign or malignant. It's, you know, follicular lesion of undetermined significance, you know, follicular neoplasm. Well, the most important thing for those follicular neoplasms or these, you know, indeterminate nodules is determining benign from malignant. And many ways in which to do that, right, is to evaluate the capsule or the periphery of the nodule entirely. So if you have a nodule in the thyroid, right, say it's here, and you're cutting it completely perpendicularly like this, you're getting essentially an en face section of the pole of this nodule. So you're basically looking at, you know, a capsule. How do you really actually determine if there's capsular invasion? You have to look at it perpendicularly, right, to see if the tumor goes through the capsule. So how are we best going to do that? So we would want to section the poles of this nodule perpendicularly and then the center longitudinally. It's like a specimen within a specimen, right? Because then this part of normal up here doesn't matter so much. This central goo doesn't matter so much. What matters is these guys, and what matters is these guys, right? So I like to think of these large indeterminate nodules as kind of specimens within specimens. And one of the ways that has been proposed to Grossing so that you correctly identify where the poles of the nodule are is as follows. So this may or may not apply to the thyroid you're Grossing today because you have one nice looking lobe with a big old boyer hanging off the side, right? So, yeah, okay, so we might imagine that if the nodule expands the tissue so much that you can see the tip of the nodule grossly and the tip of the nodule grossly, great. For yours, you can already probably take your tip of that pedunculated thing, right, and section it like this, and take your other tip and section it like this, and take your middle and section it like this. But when you have a nodule that's buried in something that you can't see, you might be able to tell that the bottom of the nodule is up at the bottom of the lobe, for example, but you don't know where it ends in the gland. Does that make sense? Okay? So in order to determine where the nodule begins and ends, if you cannot see it grossly on the surface, is to sort of fillet it open first, okay? So this, they sometimes call the modified transverse vertical method. So this is just conventional transverse. This is how we've done thyroid for ages. And this is the modified transverse vertical. So the first thing you're going to do, of course, is weigh, measure, ink, whatever, right? So there's your isthmic margin right there. And so you're going to want to section it perpendicular, I guess, what am I trying to say? Longitudinally, right? In a plane that makes sense. So sometimes the sagittal plane makes sense. Sometimes the coronal plane makes sense. In this case, it's probably going to be kind of the coronal plane, okay? Because it's long like this. So we'll take this and bisect it, fillet it in the coronal plane. All right, so now you have an anterior half and a posterior half. And you can see where the nozzle begins and ends. And then you can choose, if appropriate, right, to take the poles of your nozzle perpendicularly. So just like with this, right, if you see that the pole of your nozzle, let's pretend that, I don't know, maybe that little guy is the pole of your nozzle, right? If that's the pole of your nozzle, you're not going to, for example, I have here. All right, if that's the pole of your nozzle, right? Okay, then your normal thyroid you can section in your 3 millimeter slices. But once you get here, you're going to want to say, oh, no, I want to make that longer. I want to make that deeper so that I can then take my drawn-on pole of nodule, right, my drawn-on pole of nodule, and section it perpendicular to that nodule capsule. Right now, the nodule may have a capsule. The thyroid doesn't have a capsule, but the nodule may have a capsule. So then you can submit those sections such that these are always, the plane of tissue is always sticky. All right, there you go. So now you can submit these cut side down, right, so that you'll be able to see how the tumor interfaces with the capsule as opposed to looking at it head on. Okay? And then the rest of your sections you do normally, and then your other pole of nodule, same thing. Okay? Same thing with submitting. You know, if you're going to submit it all in order, right? Walk us from top to bottom. Just like you would with the tongue, walk us in the direction of the specimen, because jumping from slice 1 to slice 5 to slice 9 and back can be confusing. So if you're going to submit it all, submit it sequentially. Even if you're not going to submit it all, if it's big and you're going to do reps, arguably, you could still submit it sequentially, because then we still walk through the specimen in order. Guidelines, you know, if a lobe is like 10 or a total is like 20, that's probably a weight, grams. That's a weight at which you might be able to submit it entirely because there's not that many consents. That's my kind of rule of thumb. 10 to 20, if you want to submit entirely, it's fine. Okay. What other comments do we have? It's 9 o'clock. Awesome. So I think we'll stop here with mucosa and thyroid. If we want to organize another demo with larynx, we can definitely do that. And I can continue to fix this. The thing with larynx, the thing with most complicated head and neck specimens that are, you know, beyond like this, call us. We love to come see them. Mandibles, maxillas, larynxes, anything complicated. One, because most of the important information from these that tend to be squamous cell carcinomas, right, is gathered at the time of growth. You know, microscopy, yes, is important, but the growth drives the microscopy and that drives the staging. So you can get a good growth estimate of tumor locations, anatomic, you know, boundaries. Every single one of these is different, right? These are, you know, these are little beautiful golden flowers, right? That like not a single one is the same as the other. And so it's really, really helpful if one resident is triaging it, one resident is grossing it, another resident is finding it out, a fellow is presenting it at tumor boards, and a funding is looking at it. That's like too many people, right? Too many people. So we try to narrow that amount of people and have limited one resident who triages it, one resident who grosses it, hopefully one resident who finds it out, but if the resident goes off service, at least the attending and or fellow have actually seen the specimen, they know what's going on, and have a much easier time at finding it out and presenting it at tumor boards. And head and neck is one of those specialties where there often are questions about location of margin or how is it oriented. And so taking those photographs of both the growth and the cut sections has been extremely helpful. And many of you have been involved in situations where we've shown those photographs to the surgeon and said, your margin is here, right? Or this is why we think it's positive or negative. So those are extremely, extremely, extremely important. So thank you for taking those photographs. They don't just go into the ether. You really do use them. What else? So how but similar to the tongue, how do you know that? Yeah, so right. So if you're talking about what to submit for purposes of the margin, you'll want to submit whatever's closest to the end. If you're talking about submitting just representative sections of that internal tumor capsule, then that's arbitrary because you don't know where you might find a focus capsule. And so if there are any worries and features on histology, you can go back and submit more if there are other worries in foci. But in this case, it's essentially like if you have a big ball, it's like, am I going to submit here, 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 here? Well, you're going to do reps from all of those various sites, whatever our guidelines are, at least 1 centimeter, whatever it is. And then it's based on the microscopic exam that we can go back and submit more if we are worried enough. So it's kind of luck of the draw, which is why some people say submit the entire capsule up front. I say submit a good bit of it up front. And then if we need to go back for more, we can, because sometimes it's, again, an issue of oversampling where it's maybe not a real capsule, or there really are no words and features, then I don't need 100 sections of capsule, right? But if I do see hypercellularity or a true capsule, then we can go back and submit more, and then nothing will come off. Okay. Eric, next time. You prefer, I think I have a normal histology at some point. You want to swap that out for larynx or you want to keep a normal histo? Guys, how do you
For continuity,
Yeah, finish.
yeah, maybe for continuity we can finish
Finish the
roasting,
roasting?
and we have
Okay.
other, you can certainly find a time for
Okay.
normal.
Okay, yeah, I was gonna say, because I have a normal head neck histology lecture that we can replace out for roasting of malaria. Okay, because there's a lot of resources on normal histology. We can always add that in later, but since we have this, we'll swap that out.
I think
Okay,
that's
great.
good.
We have a plan.
Right.
Love it.
Thank you, everybody.
Thank you.